Indian Health Service COVID-19 Clinical Readiness and Patient Care Project ECHO Teleeducation Session for November 19th, 2020. My name is Sean D'Andrea. I'm the Chief Clinical Consultant for Emergency Medicine for IHS. We want to waste no time and get right into our agenda because we have a very full session today. First, we're going to start with a clinical update from Dr. John Irolu, the Chief Clinical Consultant for Infectious Disease for IHS. And then we'll have a joint presentation by representatives from the IHS Vaccine Task Force. Hard to imagine a more timely subject at the moment, by Commanders Kaylee Fretland and Holly Van Loo. We're very fortunate that they're able to carve time out of an incredibly busy schedule, as I think everyone can imagine, to hear about vaccine development and much more. Given we always invite questions throughout the presentation, though, given the extent of the content that our speakers are going to be attempting to share today, we would really encourage everyone to share your questions and comments in the chat feature of Zoom throughout the discussion. And our presenters have promised to try to address those as we go. Of course, we'll try to leave time at the end for a Q&A. But given that this is going to be quite a full discussion, if you have questions, please submit them in the chat. Don't forget to complete the post-session survey. A link for this will be shared in the chat towards the end of the presentation. That's how you can get CME credit. The record button is on. This is a recorded session, and your attendance and participation serves as consent to be recorded. The recording will be made available for distribution following the session. Please see the announcement slides for a copy of the please see the announcement email for a copy of our presenters' slides. And again, CME credit is available following the session after completion of the post-session evaluation. And with that, I want to turn the floor quickly over to Dr. John Irolu, Chief Clinical Consultant for Infectious Disease for IHS, to share a clinical update. Thank you, Dr. Irolu.
Thanks very much for the intro. Let's get started. Next slide, please. So I have nothing to disclose, as usual. So starting off with a kind of a sad topic, in Denmark, they've identified what they call a cluster 5 variant of the SARS CoV-2 virus. On November 6, in WHO Outbreak News, they stated that there had been 214 humans who caught this new cluster 5 variant from some mink farms. So the problem with this virus is that it has a mutation that makes it have decreased sensitivity to neutralizing antibodies. We have no idea what the human impact is going to be, but it's a little worrisome. And they made a decision to cull a total of 17 million minks. So this is a little bit of a concern, something that's happening on virologically, and hope it doesn't go international if it's bad. Next slide, please. So this is a good paper coming from Iceland. This shows that the humoral response to SARS-CoV-2 is durable. So this is a nice study. Iceland has a unified healthcare system, and they're able to get blood draws on 30,576 people in Iceland. They use 6 different assays. I listed them there. About 1,800 of these patients had recovered from COVID. 4,222 were in quarantine, and 23,000 had been possibly exposed, and had no exposure. And what they found was that 91% of the recovered patients still had antibody at 2 months, and this was durable going out 4 months. These people were considered to have adequate antibody levels. The risk of death in this Iceland population was extremely low at 0.3%. But they did note that if you compare the number of positive serologies to the people who actually were PCR diagnosed, the PCR missed 44% of the cases. So this is really important that they did a population-based study based on serologies. So what's the take-home message? Different from the population we serve, This is a country that has a very homogeneous population genetically, and so we don't know if these results apply to the rest of the world, but it's kind of exciting that this antibody response is sustained. Next slide, please. That comes from the New England Journal. Okay, a little more epidemiology. This is the SARS CoV-2 seroprevalence and transmission risk factors among high-risk close contacts. This is from Ng et al. In The Lancet from November 2nd. So it comes from Singapore, the first 4 months of the year, and they looked at 7,770 close contacts of persons who have COVID-19. So there were 1,800 household, 2,300 at work, and 3,500 social. And these were the contacts of 188 cases of COVID that was symptomatic. They found that the secondary attack rate was highest in the home at 5.9%, but low in the workplace and through the social context at 1.3% each. But they found, again, kind of like the Iceland studies, that these the PCR, if you just base it on symptoms, you're going to miss 62%. So you really we need to do more PCR on these contacts. What were the big 3 risk factors? Sharing a bedroom, odds ratio of 5.38 for coming down with COVID-19. Being spoken to for 30 minutes, odds ratio is 7.86, and sharing a vehicle, 3.07. So I don't want to talk for 30 minutes today. I'm going to stop after 10. So really important is that indirect contact, meal sharing, and laboratory use was not associated with infection. This comes from The Lancet. Next slide, please.
Okay, yeah, you get mixed.
So this is a paper, I'm not going to go through the details. I'd encourage you to read this paper by my colleague and friend Raj Gandhi from Mass General in Boston, Dr. Lynch from UW, and Dr. Del Rio from Emory. It's a very nice approach that would be practical for Indian health service providers and other staff who are caring for people with mild to moderate COVID. This is the kind of COVID that you see and send home. Raj and his team wrote a beautiful paper, and I'd like you to take a look at that. We've invited him to give a talk in the middle of December on how to manage COVID as an outpatient in these mild to moderate cases. So Raj is an old friend. We trained together. Next slide. So how about testing? The FDA put out a warning that the antigen tests that are out there, you have to be really careful about false positives. And they say that false positives happen when people don't follow the instructions precisely. And they they notice that these problems first arose in nursing home settings especially. So they tell you really follow the directions on the package explicitly as directed by the FDA EUA. Don't open the packages ahead of time and store them open. That causes problems with false positives. Don't read the test too soon or too late. That really messes up the false positive rate. And don't try to process too many tests all at once, because the timing is going to be off by a few minutes, and that's enough to mess up the assay. And then finally, be really careful not to cross-contaminate the work area, or to do things like don't change your gloves and PPE. It's very important to use clean PPE and gloves, even when obviously when collecting. Next, so that comes from the FDA. Next slide. What's new in the testing front? The New York Times yesterday, we all learned about this Lucira all-in-one test, which can be done at home. It's that little device in the left side of your screen down there. It has a battery in it. It is able to be used as a self-swab at home and a nasal swab. So not the deep nasopharyngeal, but a nasal swab up through age 14 and above. And then the provider should do it if the swab is used on a child less than 14. This is basically a swab where the SARS-CoV-2 RNA is reverse transcribed to cDNA. This is amplified using a technique called LAMP, or loop-mediated isothermal amplification. It's kind of like a single temperature PCR. And this can take place in half an hour in that little plastic device that's sitting there on the screen. It has a 94% positive % agreement with PCR and a 98% negative. So this is a pretty darn good test, but it costs $50. I don't see this as being something that we're going to advise all of our patients in the Indian Health Service to use. But I thought you ought to know about this new product called the Lucira All-in-One, and I left the web page for that company and also the FDA approval statement there for an EUA, not FDA approval, but emergency use authorization. Next slide, please. So what else to know about nursing homes? When you use SARS-CoV-2 antigen testing in nursing homes, you have a sensitivity of only 84 to 97% when it's used within the first 5 days. You really should use these antigen tests on persons who are symptomatic, asymptomatic when there's an outbreak in a nursing home, or when it's required by CMS. So what they say that you do, if you're going to do an antigen test, and it's positive, you don't have to confirm. You trust that in a nursing home outbreak type setting. If an antigen test is presumed negative, you're supposed to do a PCR within 48 hours. And you can do repeat testing every 3 to 7 days in that nursing home until the outbreak is over and there are no new cases for 14 days. You would just keep retesting the whole nursing home. And if healthcare personnel test positive with the antigen, you definitely want to exclude them from work until the confirmatory PCR is back. So healthcare workers slightly different from patients. Next slide, please. You can find that statement at cdc.gov. Since the last time we spoke, I think by the end of the session, remdesivir was approved on October 22nd. And it's approved officially for adults and kids over 12 years of age. Kids younger and the weights listed there, is still considered to be under EUA or emergency use authorization. You still have to fill out the informed consent type statements that you've been doing before for remdesivir. But this is to be really clear, it's approved only for inpatients. Supposed to treat 5 days on the wards, 10 days for mechanical ventilation or ECMO. It's not indicated for persons who have advanced chronic kidney disease or GFR less than 30. And then they changed the guidance about liver disease. They took out the requirement that at the start they have to be less than 5 times the upper limit of normal ALT level. But they do warn you that if the ALT level rises to above 10 times ULN, you need to stop the medicine. So that's the remdesivir story. Next slide, please. So how about that solidarity trial? People were talking about this. They took 11,000 adults. This is a WHO study looking at repurposed antiviral drugs. They randomized these 11,000 people into a remdesivir, lopinavir, interferon, lopinavir, and interferon alone arm. And about a quarter of them received the remdesivir. The death rate was essentially equivalent in the treatment versus controls who got and did not get remdesivir. And there was no improvement in mortality, shortened hospitalization, or decreased use of ventilation. The FDA concludes that this study doesn't really add anything new. We already knew that there's no mortality benefit, and they believe that the ACTT study is better suited. It was designed in a better way to prove that there is an improvement in time to recovery and odds of improvement. So the FDA decided to approve remdesivir based on the ACTT study, not this solidarity study. So solidarity it just basically confirms the mortality lack of benefit. And you can see that as on medrx.org at that link down there at the bottom of the screen. Next slide, please. Okay, nebulized interferon beta 1A. This is a trial in the UK. They looked at 9 sites. They gave 101 patients who had COVID-19 based on a positive PCR age 18 or older and were admitted to the hospital. And they randomized these people to receive either nebulized interferon beta 1A or a placebo, and about 2/3 were on oxygen at the time if they were enrolled in the study. And what they said was that there was a greater odds of improvement using the WHO OSCI score, the ordinal scale for clinical improvement. So the odds ratio was 2.32 for improvement. And what they did not comment on mortality. What they found was that 3 placebo patients died and 0 in the SNG 001 recipients died. So not powered to, the study is not powered to show a mortality benefit, but it is kind of interesting. So this isn't the standard of care, but it's good to know about this drug. It may be in our armamentarium someday. Next slide, please. Tocilizumab, we've heard about these biologics being touted as the treatment for the, quote, cytokine storm during the immune phase of COVID-19 disease. This paper from the New England Journal basically buries that concept, and we're not going to be using tocilizumab for preventing intubation in people who are moderately ill with COVID. Next slide, please. How about BAM? You've probably heard that this drug is being given to the Indian Health Service and may be distributed in small quantities sometime soon. This is a monoclonal spike protein antibody that appears to have a benefit not in mortality and not in the hospitalized patient. It's good for the person who comes in with mild COVID disease to an emergency room. And when you give the drug, the chance of there being a repeat emergency department visit or a hospitalization is only 3% compared with 10% for placebo. So this drug is an infusion. It keeps people from coming back to the emergency room, no bounce backs and no admissions. It was granted an EUA by the FDA to treat mild to moderate COVID. It's not for hospitalized patients. It's not for people on oxygen or who have their oxygen requirement bumped. The downside is it requires an hour-long infusion and an hour-long observation period. So it is being distributed across the Indian Health Service. We believe, I think that the shipments already went out, but be aware that you have to do it in a you want to do this in like a COVID isolation room, or you're going to really tie up your emergency room beds. It does not have an effect on mortality. And lastly, the National Institutes of Health yesterday stated that this is not the standard of care. It's not mandatory to use this drug. So this is something we've been offered. We're probably going to try using it in our practice here, but it's not like if you don't give it, you're doing a bad job. Next slide, please. And then just to close, infection control. This is a paper worth reading about. It recommends that we wear N95s when we are working in a COVID inpatient care ward. And I think our ER doctors tend to do this anyway in the outpatient setting. But if you want to read an interesting paper on this topic, I thought I brought this to your attention. Next slide, please. So the standard sites we recommend that you look at if you want to get some good advice, especially the ACP Physician Handbook, and then the NIH guidelines are my 2 go-tos. Next slide, please. So we'll close with a picture of my uncle's driveway. That's my uncle in the back with his arms stretched out. This page is a metaphor for the year 2020. We were hoping to go on a trip, but a delivery man dumped a huge pile with tons of rock right in the middle of the driveway, so we got stuck. But I'd like to point out that there are some tools in the scene. On the right, there is a sledgehammer. That's probably the COVID vaccines that you're about to hear about, and then there's just the brute strength using that pry bar in the middle. And eventually we were able to get all those big rocks moved out and could get our vehicles moving again. So with that, I'd like to turn things over to the next speakers.
Thank you so much. That's a wonderful metaphor, Dr. Iralu, and thanks again, as always, for keeping us up to the minute with the latest therapeutics and relevant findings in the literature that's available around COVID-19. I just wanted to quickly bring everybody's attention to the chat because I did share information about upcoming sessions through the first week of January. On December 3rd, we'll be talking with colleagues from the Bemidji area and Brigham and Women's Hospital about testing resource and diagnostics. On December 17th, as Dr. Iralu pointed out, we'll be joined by Dr. Raj Gandhi. And on January 7th, Dr. Anthony Fauci is going to be providing an update on this call regarding the COVID-19 response. So please save the dates for those sessions. And without further ado, want to turn the floor, the remainder of the time, over to our colleagues, Commander Holly Van Loo from the Phoenix area and Commander Kaylee Fretland from the Bemidji area, who have been working tirelessly, putting in impossible to count numbers of hours on the IHS vaccine task force. So thank you to you both for your time today, your time throughout your work in the pandemic, and really excited to hear what you have to say. Thanks.
All right, thanks so much. My name is Commander Holly Van Loo. I'm going to give a brief introduction and then we're going to get right into our slides. I am a pharmacist. I work at Phoenix Indian Medical Center, where I coordinate and manage the vaccine program there, both adult and pediatric, including the VFC vaccine. We administer about 45,000 doses on campus. I run a lot of the components, whether that's ordering, inventory, management, formulary components, all those things, as well as a lot of the flu vaccine events that we have ongoing now. So with that, that's a little bit about me, and I'm going to turn it over to Commander Kaylee Fretland. She'll introduce herself, and then we'll move right into the presentation.
Okay, thanks, Commander Van Loo. So my name is Commander Kaylee Fretland. I'm a pharmacy director at the Red Lake Indian Health Service in northern Minnesota, where it is much colder than it is in Arizona, where Holly is. I've been up here since 2012 as a clinical pharmacist and as an acting pharmacy director. I've also been through the incident command, our logistics officer. So Holly and I are bringing two different sets of experiences with the Indian Health Services Vaccine Task Force. So we're excited to be able to present to you today to talk about both the task force and then get into some more clinical information about the vaccines with some of the information that we have available for right now. So let's get started. We do recognize that we may go through these a little bit faster. If you do have questions, please put those in the chat box, and Commander Van Loo and I will respond to those as we get an opportunity. The objectives are listed. All right. I think for most of you as practitioners, you recognize this more than anybody, but how much COVID has disproportionately impacted our American Indian and Alaska Native communities. We do know that a lot of the preventive measures that have been in place, the mask mandates, social distancing, the curfews, hand hygiene are so extremely important in curbing the tide with COVID. But we do recognize vaccines as a public health countermeasure is extremely important, just as Dr. Iralu had shown in that very nice picture representing essentially what vaccines can do. And we know that vaccines do this when it comes to disease prevention. So the CDC, along with IHS, has been working with Operation Warp Speed to plan and implement COVID vaccinations. So as soon as vaccine is ready to go and gets approved, that we're ready to implement those vaccines within our communities. I want to give just a little bit of background on Operation Warp Speed, just to level set some information. And I think it's important as we walk through this, we really had multiple purposes with this presentation. We've changed this a little bit from our overall just vaccine task force overview. We really wanted to give a little bit more clinical in-depth. We recognize that not only are healthcare personnel going to be our first line and first priority patients that are going to get vaccinated or are supposed to be vaccinated, you are also our vaccinators. So you are going to be giving that information to your patients, to your colleagues. You're going to be the spokespeople for the vaccine. You're handling all those questions because as a trusted healthcare provider, that's who the patients are turning to. So we want to make sure that we are helping provide some of that information today to you to be able to share. So I think we all know Operation Warp Speed. The goal overall is to produce and deliver 300 million doses of safe and effective vaccines. It's a collaboration between Health and Human Services and the Department of Defense. And having been at Operation Warp Speed in the Vaccine Operations Center, I can tell you it is an operation. It is a DOD certainly has the is able to operationalize this vaccine to get this done in such a short period of time. There's a few different strategies that have been released. Operation Warp Speed has released a strategy for distributing the COVID vaccine. The CDC has released 2 different versions of their playbook to help with jurisdiction readiness. The first version was released back in September, and the second version, the end of October. Both, the second version is updated and available on their website. Additionally, FDA released in June June 2020 some additional guidance on how they were going to be reviewing vaccines, really to help increase confidence and make it a transparent process. When we hear Operation Warp Speed, there's a lot of fear with that, and that things are being key and critical steps are being skipped or missed. So we're going to walk through some of those timelines. As well, we know that CDC's Advisory Committee on Immunization Practices are going to independently review and make vaccine recommendations. So we have both the FDA independently reviewing the EUAs that will be submitted, as well as ACIP is going to be independently reviewing. So this is really warp speed. This demonstrates what a typical process of vaccine development is going to be, which is typically 73 months to completion. What's being done now is in about 14 months and actually even less. So I really liked this slide because I think it really showed how things are happening in parallel. So normally we go step by step. We do one process, then we go to the next. But with this enhanced process under Operation Warp Speed, things are happening at the same time. So things that normally would not have been happening at the same time are now doing that, which are shortening the process. So none of the key steps are getting missed. All of the same safety reviews are happening. They're just happening in conjunction with each other. One of the biggest pieces is the manufacturing. So the manufacturing of the vaccine is happening as we speak. So when that EUA, when the company submits an EUA, that vaccine is going to be ready to ship out the door, and they're going to have millions and millions of doses of vaccine already ready. If the EUA never gets signed or that vaccine doesn't get the approval that it needs, those vaccines are just, they're going to be thrown away. They'll never be used. That's the benefit of the federal government having put the money up front and contracting with these companies to get this vaccine developed. The other pieces Holly's going to go into more detail about a little bit later is the types of vaccines that we're looking at, the different technology with these vaccines that are newer, that allow the vaccines to be made in a shorter period of time. So from Indian Health Services perspective, CDC has recommended that all jurisdictions be ready, and actually November 15th was our date for all jurisdictions to be ready. We are recognized, IHS is being recognized as a jurisdiction. So very similar, we have worked with VFC programs in all of our programs in our states for years and years and years. IHS has never been considered a jurisdiction. But when we went and did some state needs assessments, Commander Van Loon and I had the opportunity in August to go and do a state needs assessment in Minnesota, North Dakota, California, Florida, and Philadelphia, and sit with Operation Warp Speed as well as CDC and look at their COVID-19 plans. One of the things that was really evident was that during H1N1, American Indian Alaska Natives and our communities were not prioritized for vaccine, and that really hurt our communities. And so CDC recognized that it was very important that IHS be considered a jurisdiction for COVID because we know our communities, we will prioritize our communities as well. So at that time, we started really standing up a VFC program or an immunization program for the agency. We've typically done influenza, we've tracked influenza, our practitioners are amazing at giving vaccinations, but actually being considered a jurisdiction has a lot more logistics associated with it. So whereas states have had decades to stand up their vaccine programs, IHS is really getting this done in just a couple of short months. So we are collaborating closely with our federal partners. We have a CDC federal entities team that we work with all the time that have been helping us through this process. So our vaccine task force was developed in September under the incident command for IHS. And at the time it was a planning committee, and we submitted to incident command the concept of a task force so that we could plan and be ready to implement COVID vaccine. We just want to show a graphic of the vaccine task force is comprised of a lead, who's Rear Admiral Francis Frazier, the director of OPHS, Holly and I as the deputy leads, and we have 6 amazing team leads, really specialists within their area. So prioritization is led by Captain Tom Weiser. Vaccine administration is led by Commander Angela Fallon, a nurse. Communications, Ms. Jennifer Bushik at PAS. Data management is being led by OIT, Commander Andrea Scott. Safety and monitoring, Captain Matt Clark with NPTC. And distribution is being led by NSSC's Commander Andrea Climo. They have built their teams with experts and SMEs within their area so that they are getting all of the different things and components that we need to be ready for vaccine. I'm not going to go into detail with this, it's a little busy, but this is just an overall timeline of some of the key points. And we are happy to share that our vaccine plan, which we've been working on for a couple months now, we submitted the first plan early in October. It was released October 14th as a draft plan, open for comment. And then we submitted our final plan for HHS clearance on November 6th. And that plan is clearing today. So I'm guessing you'll hear more about that as we go throughout the day, and probably some emails coming forth on that. So what's in our pandemic plan? Shortly this afternoon, you'll be able to find our updated plan on the website, so ihs.gov/coronavirus/vaccine. It really shows how we are operationalizing and making plans for COVID-19 vaccine for our ITUs. It provides information for the ITUs who are going to use IHS for their distribution. And I think it's important to recognize not all TUs, tribal health programs and urban Indian organizations are going to use IHS. Some have elected to use their state. And that was important because a lot of our tribes and urban programs have very good relationships with the state, and they wanted to continue those, and that's just fine. We just want to get vaccine out as fast as we can and be able to administer as many vaccines as we can to the communities who need it and our patient population. We've taken a lot of feedback from CDC as well as Tribal Consultation and Urban Confer to do this second plan, this vaccine plan that'll be incorporated into that. So there's a lot of different pre-planning. We've been pretty much in pre-planning this whole time. We're slowly starting to get ready to change into more of an operation so that we can implement the actual vaccine once it's ready to go. So of these key pre-planning activities, one of the first ones is program agreements. These were released last Monday to the tribes and urban programs. There's a separate tribal health program agreement and an urban Indian organization agreement. These are contracts with the CDC. IHS is coordinating the vaccine distribution. So we're still working with our areas to get these back, but this is really a key piece because we need these program agreements back in order for that facility to get into the system to be able to order vaccines and receive vaccines. So we're really working closely with our area directors and area vaccine point of contacts to get that completed. For the direct service facilities, that was actually signed under an MOA between CDC and IHS. So all the direct service facilities don't have to sign a program agreement, although we are having them complete one section, which is called Section B. These agreements are no different than what the state agreements are. And I know a lot of our sites have been getting a lot of pushback from the states to sign program agreements. Facilities only sign one program agreement. Either they sign it with the state or they sign it, the CDC agreement with IHS coordinating. They don't sign both, and they're not able to sign both. CDC has been very adamant that they can just sign one agreement. And that really has to do with all the logistics that goes into the reporting requirements with COVID-19 vaccine, with the inventory and ordering pieces. We have worked with our area vaccine point of contacts as well as our tribal ITUs to identify critical patient and total population estimates. So we utilized both some early information from CDC's guidance and playbook that they released, as well as the National Academy of Science, Engineering, and Medicine released some early guidance on priority populations. We use these priority populations to send out to the ITUs to really look at what number do you think you're going to vaccinate and how many do you have within these target populations. So we wanted them to respond back with how many they have within those healthcare personnel, both direct, non-direct, EMS, essential workers, elders, and we left elders, we didn't put an age on that. We left that open, knowing that our community's elders are certainly younger than 65. We did chronic disease, we did long-term care patients, and then we did the total amount of patients that you're going to need vaccine for. And we really wanted our sites to include both beneficiaries and non-beneficiaries, because we know our patients don't, they may live off reservation, they may live out of the community, they may have households with beneficiaries and non-beneficiaries. We have several non-beneficiaries that work in our communities, that are essential workers, and we recognize as a public health response that we need to be sure that we're vaccinating everyone who we can. So we left that open. These are the numbers we actually submitted to CDC in Operation Warp Speed. We did not submit user POPs. We took the numbers that the ITUs provided back to us. Those are the numbers that we provided. You'll get to see those here in a couple slides. We're also doing phase 1 planning, and this is so critical because phase 1 is going to be very limited vaccine, as well as the ordering documentation platforms and multiple training resources and tools that we're getting ready to share with our healthcare personnel and our vaccinators. So I talked about phase 1. This is CDC's slide. Actually, this was released on the Advisory Committee for Immunization Practices public presentation. But phase 1 is going to be very limited doses. So we don't anticipate we're going to have a lot of vaccine available at this time. So it's going to be very targeted on who those priority populations are. So we anticipate that healthcare personnel and EMS are going to be that first population that is going to be vaccinated. From there, we're going to go to other high-risk populations. So people with high-risk conditions, our elders, those living in long-term care facilities, and then going to our essential workers, and then coming back, making sure we get all those people in those first groups, as well as young adults, children, or other critical workers before we really go to the general population or the general healthy adults. So our focus is really looking at phase 1 because this has to be so targeted. And we know in phase 1, the vaccines that Commander Van Loo's going to talk about, there's a lot of logistics with some of those vaccines. We don't know how many we're going to get, but we are making micro-planning assessments and planning some scenarios for those supplies. So we know that during phase 1, if it's ultra cold or vaccine A, the logistics with that particular vaccine mean that we need to coordinate this in a more regional scale. So we're utilizing our area offices and our area vaccine point of contacts to assist in coordinating the ultra cold vaccine, which has to be stored at that -70 to -80 degrees Celsius. We have our numbers of how we're looking at this. We do recognize that tribes, ITUs are able to define their own priority populations. From an agency level, we're looking at our healthcare personnel. We're going to get vaccine allocated out to those folks first. But tribes, once they, or ITUs, once they get that vaccine at their facility, they can change that prioritization. If they have other key groups that they want to prioritize the vaccine for that are included under the EUA, they're able to do that. So I just talked about the prioritization. We are still waiting final guidance on ACIP for that. And likely what will happen is once the manufacturers submit a EUA request and the EUA gets approved, ACIP will meet after that EUA gets approved. We don't know how long it'll take. It could take a couple of days. It could take up to a couple of weeks. Once ACIP has released its guidance, that's going to trigger the ability to be able to use the vaccines. We talked about the healthcare personnel as well as additional priority groups, and you do realize that it does say age 65 and older, but please recognize from an agency perspective, we left that as just elders. So how many people do we have? This is what we've received back from the ITUs. So for healthcare personnel, and this is for the facilities that are going with IHS for their distribution, we have just over 43,000. Residents in long-term care, we had initially around 3,000 to 4,000, but because we had information from Binex now, we included that information in our numbers. So it was 76,000. Elders, 374,000 high risk for COVID illnesses. That included a list of ICD-10 codes that we provided out when we did the pre-planning tool, and that was close to 900,000. Essential workers, which normally is not captured in any of our data, was 120,000. So about 3 times what we have for healthcare personnel. And our total estimated people we anticipate that will receive COVID-19 vaccine is just over 2 million, which overall puts us at about 0.5% of the population. And as they allocate, and we heard General Perna share that yesterday on a press conference, it's really going to be population-based. So when we look at all the jurisdictions and we look at population-based, we can make our best estimates for allocation right now in some of our micro-planning based on populations. We do have a healthcare provider personnel survey that was initiated about a week and a half ago. We have over 7,500 results as of last night. That survey is open until tomorrow. If you have not gotten a chance to do that, I really encourage you to take that. And this survey is serving a lot of different purposes. It's going to help just nationally. It's going to help us with our communication strategies. As a healthcare personnel, we want to understand what some of those barriers are that are contributing to vaccine hesitancy. From an area and local level, it's going to help with some of the micro planning and planning that they have. If they only have 30% on that survey who want to receive the vaccine, well, then there can maybe be some targeted education, as well as they probably need to make plans to go down to their next priority population sooner than later with that. So we're really excited about the results from that survey. So the link is there. If you haven't taken it, please get in and take that before tomorrow. It takes just a couple minutes. So vaccine distribution, we talked about those priority populations on ACIP, but I want to go into just a little bit more information about distribution because we do get a lot of questions on how is the vaccine going to be distributed. So I mentioned that it's going to be population-based on an allocation on a national level. Operation Warp Speed and CDC are going to allocate on population. It doesn't matter if we have ultra cold, frozen, whatever vaccine gets EUA, that's the vaccine that we're going to get. To quote someone at Operation Warp Speed, you get what you get and you can't throw a fit. So we're not going to be able to be too picky about what we get. We are going to get whatever is allocated to us. We do know that some tribes have expressed concern that they want more information and to ensure the safety of the vaccine before they order the vaccine. So we're encouraging them to work with their area vaccine point of contact, especially for the ultra cold, as that's going to be coordinated through them. When it comes to the frozen, or what we're going to refer to as vaccine B, that can actually be ordered at the local level. So sites, if they don't want to order the frozen, they don't need to because they'll be ordering that at their local levels. But for ultra cold, the plan is areas are going to distribute that out to all sites for their healthcare personnel. If a site chooses that they decide they don't want to ultra cold or they want to wait for more information, then that just needs to be coordinated with their area vaccine point of contacts. I shared an example on here of how, from an agency level, how we're going to distribute. It's going to be back to that population base, but we are looking at the individual priority groups. So we're going to look at healthcare personnel because we do recognize that from area to area, and those numbers show, or our numbers on the pre-planning tools show that it's not consistent from area to area on healthcare personnel, the percentages. And so we're going to look at one category at a time, healthcare personnel. If IHS receives 10,000 vaccines, that's roughly 25% of our overall needs for healthcare personnel, then each site theoretically would be gained about 25%. And again, that's if it's ultra cold, that will be coordinated through their area vaccine point of contacts. Another important component I mentioned in the pre-planning slide was the data reporting requirements. And this is, you know, all of these pieces are extremely big, but data reporting, this is a big one. Right now, most of our sites upload into their state immunization information systems. We asked if that was something we could use. We were told we cannot because as an agency and as a jurisdiction, we have to be responsible for our own reporting, which means CDC has to get our data for vaccine administration every 24 hours, and we can't separate that out in states' data. And so we had to find a different way to make sure that we are getting our data to the states. So essentially that's going to be required by the sites to upload every 24 hours. There's also going to be some accountability data, and that's going to include inventory, wastage, returns, and temperature excursions that we're also going to be needing. The vaccine ordering platforms, most of us as pharmacists and as VFC sites do our ordering through the immunization information systems through our sites, through our states. That's not a system we can use for this. So then we had to identify another system to use. Operation Warp Speed has actually developed one for all the federal entities to use. So it's going to be an Oracle portal that they are in the process of building and testing right now that will roll out to our sites to be able to order their vaccine brand specific in that platform. So as part of this, to get completely ready, we had to look at all the different ITs and IT, where we were at with IT software across the agency, and that's ITUs. And so we have all of our federal sites who are on RPMS EHR. Some of our tribal and urban sites are on that, but a lot of them are on COTS or commercial off-the-shelf systems. And so really identifying ways that we can get all of these systems ready to go to do the data reporting. This just shows the two different potential data flows that have been identified by OIT. So we have our RPMS EHR sites, or even COTS users, as long as they can send an HL7 2.5.1 message. But to be able to do that, they really need to be at this point that they can get these patches installed. If it's a COTS user, that's a little bit different. They need to be able to do that message. But for our RPMS EHR users, there's several components that need to happen to be able to do that, which means Windows upgrade, Health Share, and Certified Health IT 2015. That HL7 message actually goes to the IHS aggregation server, and from there it's going to be uploaded to the CDC. I think it's important to stop and just make sure that we're clear. Sites who are currently uploading to their state, if that's part of their normal process, will be able to continue to do that, but they will also have to do this in addition. That data will be deduplicated and de-identified at the CDC data lake spot before it gets to Operation Warp Speed and CDC. For sites that are not going to be able to do the HL7 message, there's an alternative, and it's called VAMS. And this is a CDC platform that was developed specifically for pandemic vaccine. So they're just rolling this out now. Actually, there's training happening today for IHS, ITU users on VAMS. And so VAMS for federal, it's going to be required for employees to document their employee COVID vaccines in VAMS. It's also going to be an option for sites who are not able to meet and get the patches installed to do the messages. And then for tribes, they're going to have the option. If they can send an HL7 message, they can document in their EHR or they can utilize VAMS. So they'll be able to go either pathway. From the ordering, I mentioned an Oracle portal, and I wanted to show that this is not that much different than what we're doing right now with state orders and for those sites that are using their states. At the site level, you'll put an order in, it'll go into an Oracle portal, it gets reviewed by NSSC, and one batch order gets uploaded into what's called VTRAX and gets sent to the CDC. The state does the exact same thing. At a local site, you put it in through your IIS, the state reviews those orders, and then they submit through VTRAX to CDC. So I think it is important to remember that this process isn't going to be significantly different for our sites. One of our goals is, Holly and I are both pharmacists, we are both vaccinators, we know, and we want to try to minimize the duplicate entry and the multiple portals and the time it's going to take to do the documentation. So please know that we are trying to do everything we can to minimize that. As frontline staff ourselves, we understand how important that is at a site. And I'm going to turn it over to Commander Van Loo to finish out the presentation. And I'm sorry, Holly, I didn't leave you a whole lot of time, but.
Oh, not much time at all. Okay, so to move quickly through a multitude of information, I'm going to go ahead and share my screen so I can have control. Can you guys see my screen okay? I'm not seeing it yet.
Holly, we see section 1, vaccine availability.
Oh, darn it. Hold on.
And while you're making that change, I'll draw everyone's attention to the chat. Commander Van Loo has done a heroic job responding to a lot of great questions coming up. So take a quick look at the chat for some additional information.
Okay. I think maybe we're there. Okay, so talking about pre-planning and moving forward, because I can't wait much longer. Program agreements. Program agreements, I think Kaylee touched on this already. All tribes and urban Indian organizations will be required to have a program agreement in place, much like they would if they decided to go through the state. Each facility will need to sign that agreement. For all IHS direct facilities, there is a single MOA that is being signed. Hold on a moment. I think I might be missing something. Can you guys see?
You see vaccine pre-planning.
Okay, are we at vaccine distribution here? I think my screen is not sharing the right way. Hold on.
Not yet. Sometimes if you stop share and then reshare.
There we go. I hope that works.
Vaccine distribution. Yeah.
Okay, terrific. That's where we need to be. So for priority populations, I don't think we're at distribution. We're at further here. I'm sorry. Training resources and tools, this is where we need to be. Phew, this is my area for sure. So we are providing and will provide at a central repository all of the training and resources needed for each facility and the site points of contact for storage and handling these vaccines, they are quite complex. We have some vaccines that are ultra cold, some that are frozen, and ultimately some that may be refrigerated with variable stability at different temperature points. So those training and resource materials will be coming from the manufacturers and from the CDC, and those will be stored on the website that we referred to and it was linked to in the chat. And go work through the vaccine administration, how to mix these vaccines, how to store these vaccines, how to administer them, and some of the considerations. There are also a number of different frequently asked questions that not just IHS has, those are more program related, but also the CDC vaccine FAQs are really helpful. If you get a moment to look through those, it describes in lay language a lot of materials and information about the vaccines. We're also working on, at a national level, trying to create as many things as we can to assist the site. So we're creating note templates, we're creating forms that can be utilized in downtime scenarios or for documentation purposes temporarily until it can be entered into the electronic health record or the alternate flow, which would be VAMS. We're working on creating a standing order. We're not 100% determined on whether we will be able to sign a standing order for the entire Indian Health Service. Likely, we will create a template that can be implemented at the local service unit site. To talk a little bit about an emergency use authorization before we get into the vaccines, just a reminder that these are this information is based on available safety data from the clinical trials. This is allowing use of a product to be used when there are no available alternatives. But it still must meet the threshold of safety and a number of requirements before a vaccine can be authorized under an EUA or an emergency use authorization. The vaccine could later move to full licensure at a later time. This occurred with not the vaccine, but the product called remdesivir that was originally authorized under an EUA and now has been fully licensed. Safety and monitoring is something that is critical with this vaccine. Within Indian Health Service specifically, we have a number of different tools in our toolbox to assist with documentation and monitoring of safety with these vaccines. So first would be passive reporting with VAERS. CDC and FDA have worked with Indian Health Service to actually develop and implement a section where we can receive our own data that's reported from the Indian Health Service, and I'll show that in just one moment. We also have active monitoring, where we have sentinel site surveillance. A number of sites, at least 40 across the country, are being utilized to gather information about different products, for example, remdesivir and dexamethasone. And all this data is reported centrally to our National Pharmacy and Therapeutics Pharmacovigilance team, where they are going to be evaluating specifically for this vaccine, the vaccines coming out, early safety signals, and we will share that information with the CDC. There is a new system called the V-Safe. It's an interesting new option for patients after administration of vaccination. They can scan a QR code, and that can be utilized to enroll, where it authorizes the V-Safe program to contact them at intervals several weeks after vaccination, then several months after vaccination as well. This is a screenshot of the VAERS documentation that you may have seen previously, but specifically it allows for us to type in IHS in item number 26 on the VAERS report, so that information does filter directly to the Indian Health Service for us to see and monitor our population. This is a little more information about the V-Safe. So it is a smartphone-based system, and here are those intervals. It's weekly, daily for the first week, and then weekly until 6 weeks post-vaccination, then at 3, 6, and 12 months. If at any point someone reports something that is concerning or clinically relevant, someone from VAERS would reach out to the patient directly and create a VAERS report. So this will be really critical for us to roll out at the vaccine event, and healthcare professionals will play a very prominent role in ensuring that this vaccine safety component is rolled out. To move on to the COVID-19 vaccines in development, there are over 200 that are being developed. We're only going to talk about 2 because these are the most relevant ones right now, and that'll first be moving forward. Both of these products are mRNA vaccines. What they do is they provide instructions to our cells to make a viral protein, which can be used to recognize this invader in our immune system. So a lot of them are, many vaccines are in development. There are about 6 that are leading the way and are most likely to be released in the next, within the next year. 5 of those 6 are a 2-dose series, which really leads to a lot of complexity with these vaccinations. They will be brand specific. And so if you complete if you get 1 dose of a vaccine, you would need to complete the 2nd dose of that same brand. They all have variable storage requirements, which again lends to the complexity of these vaccines. One of them is anticipated to be stored at refrigerated temperatures. The remainder are either frozen, and one is at an ultra cold temperature, meaning stored at -80 degrees. So what are the things we know about vaccines right now with these? Those leading candidates, the first 2 we're going to talk about are 2-dose series at 21 to 28 days. Again, they are not interchangeable for brands. There is no information about what to do if someone gets one and we can't track what brand they got the first time. So it'll be really critical that the patients maintain some sort of record, whether they will be offered a vaccination card at discharge or at administration. We would encourage people to take a photo of that, keep that card with them. Data will be reported to electronic systems. Unfortunately, it will be complex sometimes to gather that data back. Like, for example, if someone received a vaccine at my facility, but then went to a different IHS facility, it may not be easy to receive or view that data. It would require a phone call. In the very, very early phase, when Operation Warp Speed is going to push out vaccine, they will reserve that 2nd dose of vaccine. Eventually, when more vaccines available in the marketplace, each individual facility will need to think through that 2nd dose and storage, whether they want, if they're going to more frequently order vaccine and making more plans for that 2nd dose of vaccine. One thing that is really difficult to handle as a vaccinator is that right now there's no data and no clinical trials with co-administration of vaccines with any other vaccine, the COVID vaccines with any other vaccines. So it's unlikely that we can recommend co-administration with anything else. For example, if they're there for their COVID vaccination, but they haven't gotten their flu vaccine, likely we will not be able to administer both together. We would need to administer one on one day, and there may or may not be a minimum wait time for additional vaccinations. We don't have any information at this time, nor do we know how long these vaccines will be effective. What about kits? There is right now, we're dealing with a needle shortage, but every vaccine will come with the ancillary supplies provided. So once you order vaccine, or if vaccine is shipped to you, the ancillary kit will be automatically paired up and arrive at your site. You will have a number of things in there, everything you need to prepare and administer the vaccine, whether that's with an adjuvant or not. The only thing your site would need to be able to provide is PPE, in addition to the 4 surgical masks and 2 face shields they provide per 100 doses, things like regular gloves, bandages, and sharps containers. So let's talk about these vaccines. Oh my goodness, we have 2 minutes to go. We have the first vaccine, which is the ultra cold vaccine, which is the Pfizer product. It is an mRNA vaccine. It's been studied in about 44,000 patients with a very diverse population enrolled. About 300 American Indian, Alaskan Natives were enrolled in this vaccine clinical trial. And we are anticipating that this vaccine will be distributed as early as December approximately. It is very well tolerated, which is reassuring. Many people who do get this vaccine may have mild to moderate side effects that are common with other vaccines as well, something like injection site pain, body aches, chills, or fever. For immunogenicity, we know this vaccine is creating a satisfactory immune response with neutralizing titers. And the efficacy data that was announced just about 10 days ago did confirm that this vaccine was over 90% effective in the first interim analysis. The complexity of this vaccine is that it is ultra cold. It is stored somewhere between -60 to -80, and it will arrive in a shipper that contains a large amount of dry ice, and a specific pelletized dry ice. This shipper can be incorporated. The vaccine, when it arrives, it will arrive with one free recharge or re-icing from the U.S. government, and it will last for 5 days inside that shipper with that re-icing. Once beyond that moment, you can choose to take it out of the ultra cold storage shipper and put it in your refrigerator where it will be stable for 5 days, or you could continue to re-ice up to 2 additional times, extending the duration of the storage by 5 additional days each time, so up to a maximum of 15 days in the shipper, and then you would move it to the refrigerated temperatures for that additional 5 days at refrigerated temperatures. If you choose to re-ice it on the second and third interval, you would need to provide that dry ice and need to acquire and purchase that pelletized dry ice. There will be a data logger included. It will arrive, it is GPS monitored, and you can turn off the GPS logger and then use it as a data logger for your shipper. Here's some information about the stability. I already discussed this. If you happen to have an ultra cold freezer, this vaccine would be good for up to 6 months. Operation Warp Speed is stating that's very lovely that it's good for up to 6 months, but they really want this vaccine to be received and administered as quickly as possible so we can start moving from our priority groups into the general population. This vaccine also must be diluted. Once it is diluted, it is a 5-dose multi-dose vial. Once it's diluted, it's only good for 6 hours. So that's something to consider as we start to create some create our events and how we're going to set them up. So I know, for example, we were talking with a pharmacist, and she was saying, "Oh, I may be traveling and this, that, or the other thing." And we said, she said, maybe I could get it on a Saturday. That way it would be easier. And we said, well, if you're getting this 1 dose, you better bring 4 friends, because it's a 5-dose multi-dose vial, and we're not willing to waste it. This vaccine does come in increments of 975 doses currently, which creates even more complexity. Not only does this vaccine have to be ultra cold storage, multi-dose vials, short stability, it also comes in a increment of 975 doses. So, and it's required for 2 doses at 0, and this one is specific for 21 days. What is the next vaccine that is expected to be coming out? Well, that would be vaccine B. Vaccine B has now completed their enrollment with over 30,000 patients. It's currently being studied for those 18 years of age and older that are non-pregnant. And specifically, they've included a number of medically high-risk patients and people who are in minority populations. We queried the company, and the manufacturer did state they estimate about 150 to 200 American Indian Alaska Native participants are currently enrolled, and the manufacturer is anticipating seeking EUA relatively soon, so likely relatively soon for availability. Great news about the tolerability. This vaccine is also well tolerated with similar side effects as vaccine A and other things like influenza, where pain at the injection site, fatigue, muscle pain, body aches, chills, fever, headache are common. We did find, or it was found in these early trials, that side effects were more common after the 2nd dose of vaccine. We've already had questions about, well, how do we determine after vaccination if they're having body aches, chills, and fever, if it's vaccine related or if it's actual COVID disease? And I would state that, we will use the same methods that we do right now when we administer flu vaccine or Shingrix vaccine. When we administer these vaccines, we know there is a likelihood that someone may feel under the weather for a day or 2. And we would advise, taking Tylenol or ibuprofen as long as you don't have any contraindications to doing so. But consider if your symptoms do last more than a few days, that could be problematic. Or if at any point you have upper respiratory symptoms or respiratory symptoms in general, shortness of breath, that would be unusual. Then you would contact your healthcare provider. We do know that this vaccine also had some efficacy data released just very recently, stating that it has availability or it has vaccine efficacy of about 94.5%. So it is very reassuring that not only are these vaccines available, but they are demonstrating efficacy in the early phases of the clinical trials. This vaccine is specifically frozen and handled, much like varicella vaccine would be. It is will be distributed directly to the site. All vaccines will be directly to the site once an order is placed. If it's ultra cold, it would ship from the manufacturer. If it's any other vaccine, it would ship through McKesson to the site. And here's some additional stability at refrigerated temperatures. And this one is much more manageable for sites that may be remote or have smaller facilities. So this one is available in increments of 100 doses with 10 multi-dose vials inside of the package with 10 doses per vial. This particular vaccine is also a 2-dose series at 0 and 28 days. As I shared with you, American Indian and Alaska Natives have been included in the study populations. Unfortunately, it's unlikely that they were recruited in sufficient numbers to truly be able to draw statistically significant conclusions, but nonetheless, we do have we are eager to share this information that our populations have been included. All right, what are considerations and next steps? We would state that it's important to continue to communicate with your area and your local sites to begin assessment and planning for this vaccine release very, very soon. Also, start reviewing some of the planning checklists that are available. We have one available on the website that's listed here. Looking at your local priority populations, defining not only however you call them in for the first dose, but how will you ensure you can get those individuals back for that second dose? Start thinking through that ultra cold vaccine. Is that even feasible for you to have at your facility? How might you acquire that? Have you spoken with your area about how they're thinking through ultra cold vaccine dissemination? Or will you choose to wait and go with the frozen vaccine or vaccine B? I say wait because they were originally anticipated that the ultra cold would be released first. We don't know at this point what the order will be because of course the EUA has not been signed for either of these products. And then also working through the training and documentation processes that are still being created. As a last reminder, we still need to maintain a multifaceted approach. We know that this vaccine is very promising and may help to curb this pandemic, but at the same point, we have to use all of our tools available, meaning using social distancing and all the other measures that can be helpful in reducing disease and spread of disease. So together, we can work together to help protect you, protect others, and use every tool that we have, make sure not only do we consider getting the COVID vaccine, but that we make sure that we have influenza vaccination for ourselves and for our families and patients. Here are some resources in case your site has interest in some information technology components to look through some of the data reporting requirements. We also have some additional information about the vaccine task force on the website. And I think that's it. Sorry, we were a few minutes over.
Thank you so much, Commander Van Loo. And I know that you all have another commitment that you have to get to and may have to drop off. Really appreciate your time and your work and on the vaccine task force. And just to let you both know, the number of folks who are on the call now are very close to the number when we started. So clearly this was of great value to the audience. So thank you both for your time today. And again, I understand that you both had a previous commitment, but we hope you all find some time to rest because it's clearly going to be quite busy for you moving forward. Thanks so much again. And we have gone just a little bit over. I think it was certainly worth it. We all have a lot to take away back to our facilities, back to our areas based on this discussion. Thanks again to our speakers, Commander Holly Van Loo, Commander Kaylee Fretland. Really appreciate your time today. Thanks to IHS headquarters for supporting our Project ECHO sessions, to Dr. John Irlu for providing regular clinical updates for us, and to the Project ECHO team for keeping our sessions running every week flawlessly and on schedule. thanks to all you for joining today. We know that everyone's gotten, unfortunately, quite a bit busier in the past month as this surge has expanded. So everyone stay safe, stay well, and we'll see you in 2 weeks for our next session. Thank you all very much.